Welcome to Piecemeal. Piecemeal is a podcast hosted by the Emily program, talking about things that are related to eating disorders, body image, and how society may influence our thinking. Please use your discretion when listening to Piecemeal and reach out for support as needed. I'm your host, Jillian Lampert, and with me today I have incredible guests. We have two highly experienced clinicians here to talk to us about ARFID. My guests today are a therapist and a dietitian, a wonder duo, if you will, that are based in one of our North Carolina sites. And really, they have a lot to do with everything that happens ARFID related, North Carolina related, lots of Emily program related things. So let me tell you who they are. Mem Wood is the regional clinical director for North Carolina for the Emily program. She holds an MS in clinical mental health counseling from Florida International University. Mem trained and worked at the Renfrew Center of South Florida before joining the Emily program, where she's served in a variety of roles for nearly 8 years. Elysse Miller is the regional nutrition manager at the Emily program's North Carolina centers. She holds a BS in health sciences from Ithaca College and an MPH in nutrition from UNC Chapel Hill. Elysse previously worked at the UNC Center of Excellence for Eating Disorders as both a clinician and a research dietitian, supporting clients across all levels of care. And these two know so much about ARFID, and we are going to learn more today because today is all about ARFID. ARFID stands for, first of all, let's start there, stands for Avoidant Restrictive Food Intake Disorder. And it's often described as like extreme picky eating, right? In the sort of social media and in the mass media, a lot of times people describe it as picky eating. But we're going to talk about what it's really all about, like who does it impact? How is treatment for people with ARFID different than people with other eating disorders? We're going to talk through all of that. So let's dive in, sort of with the basics. So whichever one of you want to start, tell us like what is ARFID? Like kick us off with a description of what ARFID is.
Thank you for having us, Jillian. We're excited to be here. So ARFID, as you said, it stands for Avoidant Restrictive Food Intake Disorder, and it's much more complex, really, than picky eating. ARFID is an eating disorder in which a person avoids or limits certain foods, not because of body image distress or like the overvaluation of weight and shape, but due to other concerns that come up for them around food. And we'll do a deeper dive around what those concerns look like. There are 3 different subtypes of ARFID. So as we unpack those, we'll talk more about what drives this eating disorder.
So, who gets ARFID? That's a great sort of opening question that we get asked a lot. Is it just younger kids that get ARFID? Can adults have ARFID too? Tell us about that.
Yeah, so initially they did think that this was really an illness that only afflicted children, and it was listed in previous versions of the Diagnostic and Statistical Manual, the DSM, of mental disorders that we reference sometimes as a feeding and eating disorder in childhood. But what we know now and what was updated in that DSM back in 2013 is that ARFID can affect folks of all ages, any background. Any age criteria related to ARFID were removed at that time when they updated the sort of diagnostic criteria for ARFID and moved it under eating disorders in the guide. And this is just relevant because that guide dictates how professionals diagnose and think about what's going on for their patients. And so it's interesting, we see more male identified patients with ARFID than with most other eating disorders when we look at who's coming into treatment, which just means that it's closer to about half and half, whereas typically with other eating disorders, we see more female identified patients coming into treatment. And sometimes their feeding or eating difficulties started very early in life, but with other subtypes of ARFID, we can see fairly sudden onset, and it can happen at any time. And like all eating disorders, there are these really complex biopsychosocial underpinnings. And so really anybody could end up having this illness.
And take us through sort of what does it look like? What are some of the struggles that parents of a child with ARFID or an adult with ARFID experience? Like, what is it like to have ARFID as an eating disorder?
Yeah, I mean, I think about this with all eating disorders, but it's really, really hard to sit with somebody that you love who's not eating, right? Like when your kid won't eat, and this happens to some extent to all of us, but it's much more extreme in the case of ARFID. You can face a lot of stress and worry about things like growth and development. For older folks, they may not still be growing, but you could be watching them, lose significant weight. There can be battles at mealtime, a lot of stress and conflict, despair about just feeling completely ill-equipped to intervene. I think as parents, like when something like that's going wrong for our children or, someone else we love and support, like we start to forget everything we know and we feel like we have just no skills, it's just, we're completely at a loss. And so I think that can be really devastating. And understandably, then folks start to make accommodations, right? Like whatever you'll eat, I'll feed you, which can then unfortunately, inadvertently further the sort of avoidance of different foods and increase things like social isolation, avoidance of normal day-to-day activities. At least you had some really good examples here of the ways this could show up.
Yeah, no, I think about this as, any sort of opportunity to like engage with food outside of the home, we need to be thinking about that, potentially accommodating for that with the accepted food. So this can include anything from lunches at school, field trips, family vacations, and as we move into the holiday season, right? A lot of holiday meals, friends, family, and oftentimes what we see is this leads to just like profound social isolation, like for the individual struggling, but sometimes also the caregivers as well.
And how about if it's an adult with ARFID? I know we see sometimes with adults, so we'll see folks coming into treatment because they've had a shift to move out of the home. Maybe they're going to college, or maybe they're moving into a new living situation. How does it show up there for that young adult?
Yeah, so, regardless of what the variable is that's sort of driving the ARFID presentation, we're generally seeing, significantly low energy intake and or we're seeing really poor dietary variety. So, macronutrient balance is off or, there's micronutrient deficiencies given maybe, again, limited dietary variety. Will you guys translate that for the non-dietitians? That's right. Yeah. So, we'll get into the subtypes in a bit here, but there can be like a lot of different reasons that somebody is struggling to meet their nutritional needs because of, experiencing ARFID. And as we said, this would be, not otherwise related to body image disturbance, right? But no matter what the variable is, the reason that they're struggling to eat, it's going to be impacting how much they eat and or from a sort of calorie perspective. And then within that, usually the balance of where those calories are coming from, right? So, with our macronutrients, our starches, our proteins, our fats, right? And then micronutrients, so vitamins and our minerals. You might see somebody who is maybe regularly meeting their energy needs, but again, that variety is really off, and that could lead to, in a more chronic way, some significant deficiencies versus somebody else who might just overall have inadequate energy intake. So, they're at an energy deficit. What this actually looks like, either in an acute or chronic way. So either if it's a sudden onset or this is a chronic condition, is that there will be interference with daily functioning, right? So the ability to have the energy or concentration to be able to participate, in school, for example, to have, the ability to participate socially. And this is a really big piece, especially when we look at adults who present for care or who are willing to get treatment for their ARFID, is about the way that interferes with their ability to live the life they want to live, right? Because there needs to generally be some type of significant consideration to food. And as we know, like eating is a really big part of social experiences. And so again, we might see, as Mem mentioned earlier, that there could be issues with chronic, growth and development. So maybe somebody who has just chronically been a low weight for age and has had height stunting because of their ARFID, or in an acute sense where there's an onset of an event and then a significant drop off in energy intake or food intake that leads to weight loss, which could be significant, which could lead to medical instability pretty rapidly.
So it sounds like if somebody is thinking about like, why would this happen? What does it look like? How does it happen? Let's dive into those sort of different types of presentations, and then we can talk a little bit more about each of those, because I think that as we see the different presentations clinically, that maybe will help folks to understand like, oh, how does that actually show up in day-to-day living, and what kinds of limitations will that present for somebody in day-to-day living that might motivate somebody or make it really clear that they need support or need treatment or need a more intensive intervention than they're currently getting. So take us through those different types or different presentations of ARFID.
Yeah, so there are three main identified subtypes of ARFID. The first would be sensory sensitivity or taste or texture aversions. And so that could look a lot of different ways, but it might be about the way a food looks, the way a food smells, the way a food sounds. It could be about, again, the texture of the food, or there being some uncertainty about the texture of the food. So I'm used to mashed potatoes that are really creamy. These look like they have lumps in and of itself that, maybe activate some type of disgust response, and I'm unable to eat the food. We see this a lot too with different types of, like add-in seasonings, anything from salt, pepper to like parsley. Just the appearance of that can have a really strong disgust response. So again, that's our first kind of sensory sensitivity subtype. The second is fear of aversive consequences. So this we generally see as one of those scenarios where we have a more abrupt disruption in intake. So there is, typically speaking, an event that leads to pretty considerable change in behavior right afterwards. And so this may or may not be related to an event, or it could be the fear of the event, but typically things like fear of choking, a fear of having an allergic reaction. Sometimes we see it as a fear of having, just maybe more delayed GI symptoms such as like constipation or irritability. And because that might feel so unpleasant to somebody, they might go to extreme lengths to avoid the sensation of that. And then the third subtype is going to be lack of interest. And so this is going to be, an individual who may forget to eat, who may be like lacking the cues to, experience hunger, or really might just be struggling with like lack of pleasure around eating.
That's super helpful because it's we often talk about eating disorders or eating disorder behaviors as more sort of extremes of sometimes kind of normally occurring occasional human experiences. And so I think it applies when we think about ARFID. Like most people can probably identify something that they just don't really like. Like maybe they don't really like, I don't really like beets. Like I don't like beets. I don't like the texture. I don't like the smell. I don't like a million things about beets. I appreciate that they're a lovely vegetable and they're so pretty, and I just cannot eat them because I have that sense of disgust around seeing beets. And that's just one food for me. And most people can sort of identify with that. Like that's a pretty normal human experience to have a food that you just don't really like and that you have a pretty strong reaction to. So I think it's really helpful in how you're describing that disgust response, that when with folks with ARFID, it's more foods. It's not just one food. It's a number of different kinds of foods or a whole selection of foods that I can live my life perfectly fine without ever eating a beet, and I can avoid beets really easily. And my friends like to tease me about how much I like to avoid beets, and it doesn't impact my life negatively, right? But if I had 20 foods or 50 foods that I can't eat or I have that same disgust response to, it would be pretty difficult for me to navigate the world. So that really fits with that, like it's more on that extreme end. And then the aversive piece, I think that also makes a ton of sense too. Like a lot of times people have an experience in life where they got sick after eating something, and maybe it had something to do with eating the food, or maybe it had nothing to do with eating the food, right? But then we associate that food with the thing. And so I think a lot of people can resonate with that. And with ARFID, if it's a really big response like a choking episode or a intractable vomiting episode or something really terrible happened, it makes sense why the brain would decide that doesn't seem safe, right? So that sort of aversive subtype of ARFID can, I think, make sense in that realm. And then that restrictive type, like we hear a lot about people who will say, oh, I forgot to eat. The societal response to that is sort of like, what? How could you possibly forget to eat, right? But as we've learned more about the neurobiology of eating disorders, I find that so helpful when we're thinking about ARFID, because the way that the brain processes disgust and how some people have just really high disgust meters. I know that's not a thing, but like really high disgust sort of detectors, or really kind of lower reward for eating responses that can really explain neurobiologically some of what's happening in ARFID. So I just like to highlight that, particularly with ARFID, I think sometimes it's easier for people to understand like, oh yeah, that's kind of how that could develop, because we all have this experience with a brain that sometimes doesn't like things. What do you see? Like, what do we see as like the concerns that get somebody to come to care? Like when we're talking to somebody who's recently admitted to any program, whether it's outpatient or IOP or PHP or residential or inpatient or wherever, like what got them there? What was the presenting thing that it's time to get some help?
So the types of things we typically see, and I think your beet example is a great one, Jillian, because, what we're seeing here is profound interference with one's ability to like engage normally with food, to be able to, participate socially in food events that, have food associated with them. And sometimes we really see significant changes and shifts in growth and development. So, I would say for maybe a child adolescent presenting to care, it might be that this is something maybe the family system was expecting the child might grow out of, but actually maybe it's actually worsened in time, right? Or maybe the degree of accommodations of those accepted foods is so significant that, the parent is flying across the country to go on vacation, but has the specific types of chicken nuggets, and they're trying to frantically figure out how am I going to keep this frozen, right? Or we're going on a vacation and I've in advance prepared a lot of the specific types of pasta that my loved one will eat. And so again, there's a sort of sometimes a family system is really organizing itself around accommodating these accepted foods because of course they want their loved one to eat. And sometimes it's just a very difficult thing to do, right? Long term. And sometimes coupled with concern from like a pediatrician, for example, around growth and development might also prompt somebody to come and seek care. And as Mem mentioned, we're seeing folks, the entire age spectrum, all levels of care. It really does seem like more and more with every kind of coming year, we're seeing more folks present with ARFID. Adults, I would say, at least anecdotally, what seems to be the case is that with a couple of these subtypes, there's significant interference with the ability to participate socially. And this might come to light as they transition to college, for example, right? Where now they want to be able to hang out in a dorm room with friends, or they want to be able to take somebody out on a date, and they can't, right? They feel like they don't actually have the skills to be able to do that. And then that we've seen really translate to motivation to seek out care and participate in treatment. In a case where there's a more sort of extreme sudden onset, it's usually a degree of medical instability that brings them in to care, right? And oftentimes it's, we are the types of treating providers that make the most sense to support somebody in renourishment, because at the higher levels of care, we can do supervised renourishment, medically monitoring early renourishment where there might be a risk of refeeding syndrome, for example. And so those are types of the main things that come to mind. Mem, would you add anything?
I mean, I think you covered most of it. One of the things I was thinking about is like with the fear of adverse consequences, for example, like someone who's really afraid of a current like choking incident or an anaphylactic allergy or something like that. Often the degree of avoidance has gotten much more extreme over time. So we see this with a lot of things related to anxiety and avoidance, right? The more we avoid, the more we avoid. And so somebody might have started, perhaps they like choked on a piece of steak, right? So they initially were like, well, I just won't have steak anymore. But then they started to get nervous about other types of meat. And then actually these other things have a similar texture. And often by the time folks come into our care, they're eating a really limited number of foods. They might have only 4 or 5 foods that they're eating at all. Or as Elysse has described with taste and texture aversions, they might have such a high degree of like brand specificity. It's like, I'm only eating Ore-Ida potatoes, like this type, And so I think that just degree of avoidance and limitation is also sometimes what brings folks in. They're like, my world has gotten smaller and smaller. I can't really like function anymore.
Yeah, that makes a lot of sense. And the next question is really around like, well, then what do we do? And let's talk a little bit about recovery from ARFID, because I think that's as a clinician, that is really exciting, I think, to me, to all of us. Like we can do a lot to help people to get better from ARFID. So I'd love to hear, each of you comment on what you've seen in your experience working with people with ARFID. What can people expect in terms of recovery? What can they expect in terms of treatment? Tell us the good news about that.
Yeah, there's a lot of good news here. There is really good treatment for ARFID, and a lot of it can be done outpatient or at lower levels of care for less extreme presentations. You know, the folks we see, we've discussed the kinds of things that might bring them into a higher level of care if there's been significant medical impact. But if it's caught earlier, there's a lot of great work that can be done in other more familiar, comfortable environments. And treatment for adults and children is really similar in practice, but might feel a little different in tone. So there's a lot of great material out there for ARFID treatment for children that is very playful, very light, because you can imagine, you know, mealtimes have become, for most families, going through this like tense, right? High conflict, just a lot of stress. And that can, you know, it's nobody's fault that happens. I'm sure, be in that same position with my kiddo. But I think it's, you know, about how we try to take away some of that pressure and help food be a more sort of playful, enjoyable experience for folks who really haven't had a lot of positive experience with food. And so there's a few things that we're trying to do in treatment for ARFID. So from the therapy perspective, the kinds of like skills and techniques we're teaching people are very similar to what we would do for any eating disorder or anxiety disorder. You know, DBT or CBT skills, things like that can be helpful across all diagnoses. But what's more specific for ARFID is going to be the way that we do exposure to reintegrate other foods and how meal times look. So I'm going to let Elysse talk a little bit about what we do at meals and then what we do when we practice what we call for our program food discovery.
That's right. Yeah. So, you know, a dietitian would be doing a thorough assessment of, you know, oral intake upon meeting the client and getting a sense of, you know, Jillian, with your example with the beets, okay, is it just beets? Is it all vegetables? Is it all fruits and vegetables? You know, is it anything that maybe feels like it's got a textural difference, like as you bite into it? Really looking at just how pervasive the avoidance is and some of the underlying kind of components that are maintaining it. And part of that assessment is about understanding or sort of anticipating, you know, micronutrient deficiency, for example, right? So looking at, you know, based on the accepted foods, are we missing out on a ton of vitamins and minerals, right? Or big picture, you know, to you know, meet their needs, they have to rely on oral supplements, which is something we see quite a bit of, but maybe they're not getting enough calories in per day, which is leading to maybe gradual weight loss over time. So, you know, that early nutritional assessment will get a sense of certainly, you know, what subtype we're working with, but also, you know, how the course of care might look. And really at any level of care, we'd be looking to really focus on those accepted foods. So the foods that feel like safer and more manageable at those meal times. So again, whether it be an outpatient, all the way up to inpatient, meal times are going to be, you know, these are the foods you're comfortable eating. Let's really focus on that because we do see quite a bit of folks who come in with some degree of weight suppression or have experienced weight loss, so need to restore some weight. Outside of meal times, we'll have a dedicated time to do some practice with these foods that are going to be challenging. And there is a really lovely collaborative approach that we would take to that includes, you know, creating a hierarchy, really understanding to, you know, the best degree that we can how these foods sort of compare to one another, all the foods that are avoided, you know, how would we sort of identify how distressing those foods are? Where do we begin? How do we, you know, begin to, you know, integrate that food? Is it just the idea of being in the same room would be a couple times would be, you know, a step in the right direction. With others, maybe it will be a little bit more kind of aggressive. But you're really working collaboratively with the individual to understand, you know, where their willingness, motivation is. And, you know, again, given the subtype, that can also determine, you know, how quickly we might be able to reintegrate foods. So from kind of the exposure, food discovery realm, and as you sort of develop and that self-efficacy, get some practice with it, you're slowly integrating those foods now back into those accepted foods and back into meal times.
Yeah, so the way I would think about this is like if we admitted someone who could only eat Tyson chicken nuggets and Ore-Ida potatoes, like breakfast, lunch, and dinner would be those things.
That's right.
Just enough of those things to help support their weight restoration if needed, so regaining some weight, but also like get them adequate nutrition. And then in their daily practice, they would be trying to integrate, you know, we might start with like another brand of chicken nuggets, right? But then work from that to could we do like grilled chicken and, you know, try to expand variety. And we can do that in a number of different ways. So like Elysse said, there's a great opportunity for just collaboration there and working with like a family too to understand their food culture, like what would be valuable to be able to integrate. And so that part of the work is really cool. And we see great results with this. I mean, we see folks make the step from like having, maybe they're just in the room with the food and eventually it's like it's on their plate in the meal room, which is what we have here at higher levels of care. And they get to a point where they can expand their variety quite a bit. And so, I think it's really cool to see that happen. The other key piece of treatment for ARFID involves targeting what we call body awareness. So, whereas for other eating disorders, we do groups at all of our levels of care around body acceptance or like coping with body image distress, folks with ARFID don't have that. What they need is generally more to do with learning about the senses of like interoception and proprioception. So understanding like how my body is in the world and then what kinds of things I'm feeling going on in my body. And so we have a curriculum that helps folks learn about the connections between like emotions and physical sensations, right? So if I'm feeling anxious, maybe there are some physical symptoms of that intensify my anxiety, make it harder to eat. How can I make sense of that in my brain? And sometimes we even do exposures with this. So we will create physical sensations for folks to practice, like understanding and tolerating them. And then they're also learning about things like how digestion functions and really understanding their bodies better. So all of these things help just build understanding and buy-in to doing this other difficult work of expanding variety and adequacy.
Yeah, that all makes sense. That was really, really helpful depictions of sort of what families might expect and people might expect to happen when they come into treatment. I think so often people come in and they think, or maybe they hesitate to come in for care because they think that we're going to somehow like take the eating disorder away from them. And we can't do that. We don't do that. We help them to develop the skills to live life without an eating disorder. But it's really scary, right? It's scary to think about change. It's scary to think about what you might get asked to do. It's scary to think about eating differently. It's scary to think about having to tolerate your body experience differently. What sort of tips would you give first sort of parents of younger kids, and then same question for an adult struggling with ARFID, but what sort of tips would you give parents or adults? Like maybe they are concerned. Maybe they think their younger child has ARFID. Maybe they think their college student is really having a hard time. What sort of advice do you have for a friend or a family member when they're concerned about somebody?
Yeah, I would say generally if, there is a suspicion that there's something going on, it's worth investigating, right? Especially if you've known somebody maybe at a point where their relationship with food was more normative and now things feel like they're different and can't quite pinpoint how or why. I certainly think it's always really helpful to start with medical evaluation, looking at ideally historical growth charts to see if there has been any disruption to sort of that growth trajectory. Seeking specialized assessment is also a great way to do that. And, regardless of where, someone might live, there are great ways to do that are even virtual, right? Because, from there, you can start to get a sense of, is there something actually happening here? And to what degree is it impacting one's life? What types or level of care would be most helpful for this individual? Again, especially in a case where there's been a really sudden onset. If you're seeing really sudden weight loss, there could be profound medical risk in and of itself right there with the weight loss. And so, the idea of sort of targeting treatment and reintroducing food really should be supervised. Similarly, there is risk of ongoing, if somebody is a younger individual who is just historically, maybe lower on the percentiles, but, has height potential there, you actually with getting early care and early treatment, there's a way to change course and help somebody get back on track, right? So again, just sort of stressing that even in a more kind of chronic picture, there is risk in somebody being chronically malnourished, whether they're an adult or adolescent. And we really just like to see folks get the right level of care at the right time.
Yeah, so you're talking about connect with your pediatrician or PCP, and then when we say specialized assessment, there are some great resources out there. So certainly, yeah, at the Emily program, you could call us and we would do a level of care assessment, which is just, assessing for, is this ARFID? We don't really know what's going on. Can you help us understand what kinds of, signs and symptoms we're seeing, is this an eating disorder? We can help answer that question and then determine, like, is this stuff that could happen at, safely at outpatient, intensive outpatient? Does it need a higher level of care? A lot of eating disorder programs will do something like that if, the Emily program is not in your area. And then there are a lot of other great resources. The National Alliance for Eating Disorders, NEDA, they have a website, a phone number, an email. There's a lot of different ways to get referrals from them. IADEP is a great organization, that's IAEDP, that can help connect you to like other certified eating disorder specialists in an area if you're looking for an outpatient provider. The National Alliance for Eating Disorders, also a great resource to find care. And so lots of good free websites, no affiliation with any kind of program. The main thing would just be making sure that any eating disorder specialist or program that you connect with has appropriate treatment for ARFID, because it is a newer diagnosis. I mean, we're 12, 13 years in now, but still, like, the understanding of this illness has been developing. And so not every program has like thorough kind of treatment for ARFID. That's just something you would want to check out if that's what you're looking at. And I want to just underscore what Elysse said, like, trust your gut. If it feels like something's going on for your loved one, you're probably right. I think just expressing concern to them, doing so as like calmly and non-judgmentally as possible, is helpful. And then doing whatever you can to support them in taking the next step. If we're talking about a young adult, it's really helpful to try to like sit with them and look at a website or make that initial call to a provider, just to like reduce their anxiety and increase follow through, because we know how hard it can be to take that first step to getting help.
Absolutely. I think it's so true that don't wait. Like, don't wait. It's not a passing fad. It's, if you're, like you both said, sort of trust your gut, like family members tend to know, or loved ones of somebody tend to know, like, something's going on. Should I help them reach out for more information? Yes. Yes.
Right.
Please help them reach out. We know that eating disorders, take so much vitality and time and health from people, that reaching out sooner is better, and it's never too late, and that there's always really, great hope that people will be able to get better and move on and live a life without an eating disorder. And particularly with ARFID, there are such really great and impactful ways that people can change their trajectory with their relationship with food. So super exciting. We don't want to miss the opportunity to talk about our exciting thing happening here at the Emily program, in that we are January 14th launching a specialized residential inpatient unit for the treatment of adults with ARFID, which is unique. There's not a specialized adult unit in the country. So we're really excited about the launch of that I know both of you have a lot to do with the training and development of that unit, which will be in the Raleigh, Durham area at one of our sites there. So super excited to be sort of adding that to the mix in terms of care available. But to underscore what you're both saying, like, reach out, get help, let somebody know you're struggling, because there's a lot of reason to hope that things can be much different. So Mem, Elysse, both of you, thank you so much for spending some time with us and talking about ARFID and helping people to learn more and to share your wisdom. I really appreciate it.
Yeah, this was a pleasure. Thanks for having us, Jillian. And you know what? Elysse and I love to connect with anyone who has questions about anything eating disorder related. So feel free to throw our contact information out there too. We are always happy to connect with families or providers and just talk more about these kinds of things.
Excellent. We will definitely do that. We'll put all the information in the show notes so that people can access the resources that you mentioned and then get in touch with us. So thanks everybody for joining. We hope that makes ARFID more understandable. And if you know someone who might have ARFID, reach out for help. And if you'd like to see a topic discussed on Piecemeal, drop us a line and let us know about that too. If you enjoyed today's episode of Piecemeal, please subscribe, rate, or leave a review on Apple Podcasts or wherever you listen. Learn more about us at emilyprogram.com or find the Emily Program on social media. Piecemeal is produced by the amazing podcast team at the Emily Program. Until next time, take care. Thanks for listening.